So thank you guys all for being here, for joining us today. I know it's July and lots of people are on holidays and elsewhere, but we appreciate you coming. Those who are not able to join us can certainly still watch the recording of the webinar afterwards. We do send that out to all of our people who have RSVP'd, as well as post it on our website. And typically we get lots of views after the fact as well, because people are just sometimes busy during this time frame. So for those of you who don't know me, my name is Chanel Delorier. I am the network manager for MPN, which is the Manitoba Primary and Integrated Healthcare Innovation Network. As a network, we work together to connect researchers, clinicians, policymakers, as well as members of the public to create innovations in primary healthcare in Manitoba. We also have Jen Pepnick here with us, who is MPN's knowledge broker, and she is our technical guru. She's going to be doing the slides, as well as helping moderate the discussion afterwards. So today, one of our members at MPN and his team are going to present on their experiences with engaging the public in their work. And his project is entitled Evaluating Older Adult Care Continuums in Alberta and Manitoba, a Comparative Analysis. And so this is Dr. Malcolm Dope, who is the principal investigator on the study. He's also an associate professor in the Department of Community Health Sciences and Emergency Medicine, and a senior research scientist at the Manitoba Centre for Health Policy, as well as he's the director for the Manitoba Training Program for Health Services Research. We also have with us Dr. Tara Stewart, who is a researcher on the project as well, and she's with the Centre for Healthcare Innovation and Department of Community Health Sciences at University of Manitoba, and her work involves both grant-funded health service research and system-sponsored evaluation of healthcare services, programs, policies, and system-level changes. On this project, she's one of 4 principal researchers, and she also fills the role of community partner liaison, which is kind of a unique role, and I'm sure they're going to talk about what that means for their project. So she works to connect across the researcher team and as well the community advisor team. And then we also have Connie Newman, who is a community advisor on this project. Connie sees herself as a connector. In her previous career, she connected parents and teenagers to supports and services in her home community, and she's still doing some of that work. She also connects older adults to many services available that we need as we age through senior centers and local senior support coordination throughout the province. And she is a consultant with the Manitoba Association of Senior Centers, and she's 72 years young. So I'm gonna, that was my instruction to say that. I think you look younger than that, Connie, just so you know.
Thank you.
So I'll let you guys get started. We have lots to get through, and so we'll let them do their presentation and talk to us about their work, and then there'll be time afterwards for, I'm hoping, a really good discussion and some questions for their team.
Thank you, Chanel. Okay, so let's hop to it. Jen, if you can share the screen so people can see the slides, we will start. We have, I would say, Connie and Tara, maybe a 20-25 minute top presentation, so the lion's share of this will be for discussion if we want it. I do not see the slide deck, Jen.
I will try resharing it again. You should see it, but
I'm seeing it.
is it maybe hidden behind your screen on something?
Oh, there we go. Look at that. Okay, good. I'm good now. Okay, so however, I'm on slide 3 on mine. Back right up. First slide.
Slide 3.
There we go. Good. Perfect. Okay. So thank you everyone for coming to this. I really appreciate your time, and Chanel has given a great introduction to the 3 of us. I'd like to also thank Tara and Connie for coming to this as well. So Jen, if you could just pop me forward to the thank you slide. So this is as you'll see, a large grant. This is a fund that a group of us put in to CIHR through one of their SPORE projects a couple of years ago now, I guess. And so obviously thank you to CIHR for funding this. This is a project, as you'll see, that compares the care continuums between Alberta and Manitoba. So Alberta Health has also put funding into this to support this. But saving the best for last, I also wanted to support MPN. And just so people are aware of the granting process, this was a two-stage granting process, is where the grant went in locally. MPN made some decisions, I guess, in terms of who to support for matched fundings. And so this is a grant that got through the local followed by the national component of things. So this is a great opportunity for us to do some things with MPN. I will also say that as we've proceeded through this grant, we've ended up doing some, I would say, Tara, things with community advisement more formally than we had planned, and MPN has helped us out in a variety of ways with that. So they've not just given money, they've given lots of other things, which is phenomenal. So thank you very much. Jen, pop us forward to slide 3, please. So my rule in all of this is really just to talk about the grant. And so this is the care continuum, people that, home care, supportive housing, which is called all sorts of different things across Canada, and then nursing homes. And the premise behind all of this is that, this aspect of healthcare is going to be used more and more recently and in the times to come. And if you really start to dig down into things, we know a little bit about how these systems are used. We know that they're very different in some instances between one jurisdiction and the next, and that's about where it ends. And so this grant was really put in place to identify, compare, and contrast the continuum care structures across Alberta and Manitoba, but really looking at Winnipeg and Edmonton. The other piece of the grant that is in here was bringing the administrative data in from Edmonton into the Center for Health Policy in Manitoba and do some head-to-head comparisons about, now that we know a bit more about these systems, what are the consequences of that in terms of how people use the systems. And as you'll also see in a little bit of time, there is a lot of consultation that goes on in this grant. So trying to get consensus on areas around what requires reform, and how do we evaluate if that reform is actually doing the things that we're intending it to do. So Jen, if you can just pop me forward again, please. So this is looks kind of weird now that I see it but this is basically the approach. And so we started this out with never mind the care continuum, but doing a Delphi method with a large number of individuals. And so by that, I've 35 or 40 or so decision makers in the system, healthcare planners, and then also I think around 30 community partners in there, and doing them in parallel but separate, and asking this question of, well, never mind the system, what do people need to live successfully in the community? And that piece of the project is done. It's fascinating results. You will see that there is, in some instances, agreement between the community partners and the healthcare stakeholders, but in lots of instances, they think about different things when they do that. We've had a couple of large workshops, but one big one on discussing these results, and then a move forward plan, which is to go in and assess programs and policies that exist to support these factors. And so we're in the middle of this piece here. We've also done a great deal of work where if you start to think about the actual care continuum and go, well, how do we actually compare systems across jurisdictions? And you realize there's not much out there. And so we've created one, and we've created and applied it in the middle of analyzing results. And again, we've had a second large workshop just pre-COVID actually, that went in and talked about these results and what we think of them and how to use them. This part of it here is close to being done. We're at this stage here, and this is bringing in the administrative data to do some head-to-head comparisons, and then a final workshop, which is putting it all together. And so there's a lot of research, different types of research that's going on here, but also a large number of consultation that goes on at the same time. And so Jen, if you could just pop me ahead one more slide, please. This is the team. It's a large team. I think there's 30 people-ish on here. in the CHR grant, Connie is listed as the principal community partner on here, and here's the crew of people, some from Alberta and some from Manitoba that are with her on this. The researchers I've listed, again, from both Manitoba and Alberta. Tara's co-PI on this, as are a couple of folks from Alberta. And then our list of healthcare stakeholders, and again, split into those from Manitoba and Alberta. So lots and lots of consultation with people. Jen, help me forward one more slide. The last thing I'm going to say around all this is hopefully, Tara, by way of introduction to the things that you're going to say, and I spent a lot of time with students on this slide, actually, and this whole thing of as researchers, how do we know what evidence to create for the healthcare system that gets in this transactional space? And these are not, it's not rats in a cage we're talking about, or the color of a car or whatever. These are a lot of the stuff we're talking about is in a very complicated setting and system. And so how do we do research around all this to really maximize this transactional space? And by that I mean doing research that has pragmatic and tangible influence to the benefit of the healthcare system. And so to date in my career, I've spent a lot of time actually focusing this and trying to foster this partnership with healthcare stakeholders. But Jen, probably forward one more slide. The other thing that I've learned a ton in this project about is modifying this a little bit. And we have to keep in mind that the system is not there for the researchers to do research on, or it's not there for the decision makers to have a job or whatnot. It's there for the patient, right? And we're all patients at the same time, and so the need to make sure when we're talking about reform strategies that we have the actual people that are using the system at the table and get the knowledge from these individuals about, well, what do you think of this system, and what is missing in it from you? And I would approach measuring success in one way, but Connie would have some very different thoughts about how to measure success. And those are not right or wrong. Those are just different perspectives and different opinions. And the richness comes out of all this is getting everyone together and seeing where we agree, seeing where we think differently, and trying to find something that is a move forward pathway that is the richness that comes from those different perspectives. And so we've really tried to focus on this aspect of it in this particular grant. Chanel mentioned that Tara is the person that is leading the community partnership engagement piece on all this. And so I'm going to just flip it over to you, Tara, now to talk about details. Okay?
Sure. Hi, everybody. So picking up, I guess we can go to the next slide after Malcolm's there. So our engagement strategy, I'll tell you a little bit about how we approached this. A big part of our strategy at the outset was the intentional setup of a governance structure that involved 3 groups. So we set up a structure basically as illustrated on Malcolm's last slide. So we have a group of researchers, we have a group of healthcare stakeholders or policymakers or decision makers, whatever label you want to apply, and then a group of patient partners, or as community advisors, as we sort of call them in this particular project. So these 3 groups began to meet routinely or on an as-needed basis, typically by teleconference because we're across Manitoba and Alberta, to consider the research issues from their own unique perspectives. Each of these 2 stakeholder groups, so the policymakers and the community advisors, we had identified researcher liaisons for both of these groups. So Malcolm essentially served the role of liaison to the policymaker group, and I served in the role of liaison to the community advisor group. And in the case of the community advisor group, we set up a co-lead structure of that separate group so that myself as the researcher liaison and Connie, who you'll hear from after me, would co-lead that group of community advisors. So that was sort of how we set things up. We had a very intentional structure of the 3 groups, a very intentional liaison roles, and those 3 groups were meeting routinely or on as needed basis. And then we decided we would be pulling the groups, all 3 groups together for full team workshops. And we have 4 planned, 2 have been completed. So we could go to the next slide. So as part of these full team workshops and as part of the community advisor liaison role, we decided to put into place some additional engagement opportunities with the community advisors. And we wanted to wrap these engagement opportunities around the full workshop team meetings. So we decided to have a pre-workshop meeting with the community advisors and a post-workshop, we called it a post-workshop debrief. So the goal of the pre-workshop meeting was to just meet separately with the community advisors and the community advisor liaisons. We would review the logistics and preview the content of the upcoming full team workshop. Then the workshop would occur and a post-workshop debrief would be held. So the goal of that debrief was to invite feedback from the community advisors about what went well and what maybe didn't go so well from their perspective. Next slide. So I can tell you a bit about some of the emerging lessons that we're seeing coming out of our work. And as I say, we're 2 workshops in, and so we have those 2 experiences to draw from. The first emerging lesson, I think, is this idea of a common goal, but different priorities. So although the team is very united in a common overarching goal, so to improve the healthcare system and to better support individuals to age in place in the community, there are very real differences in the priorities about knowledge, deliverables, and timelines. And these accrue, as a result of membership in the 3 groups that we're talking about. So researchers, policymakers, and community members. So for example, researchers often prioritize generalizable knowledge and scientific publications as a deliverable, whereas policymakers may prioritize knowledge that is locally relevant, and they may prefer deliverables in the format of a briefing note or a business case, for example. Community advisors, the priority is typically knowledge that is readily applicable and deliverables in the form of very brief plain language summaries or infographics, for example. So it means that although there's a common goal, these sometimes different priorities means that there will be some extent of maybe not disagreement, but differences of opinion. And coming with that is a sense of sometimes a bit of discomfort in engaging. However, our perspective has been that if there isn't at least a little bit of uncomfortableness, then we aren't likely engaging as deeply as we want to be engaging. So that's kind of the first lesson, I guess, that's emerging for us, is that there will be differences of priority and of opinion, and that, that's the time to lean in and to continue to engage. The second lesson that we're learning in terms of engaging with the community advisors is that they really want to have information up front, and we're learning as we go in terms of how much and how to deliver that and in what format. So the community advisors really value the preparatory face-to-face pre-workshop before meeting with the full team. Things we have heard back from them is that they have felt better prepared going into that full team workshop. they have really valued the opportunity to engage with one another and to build trust with one another and with the research liaisons, because the community advisors really are bringing to the table very personal stories, and sometimes those stories, you know, can have emotions and trauma attached. And so part of the function of the pre-workshop is to kind of build that safe space and build that trust with one another and with the researcher liaison as well. So we're learning that in this pre-workshop, they want as much information up front as possible. So they want not only the when and where of the workshop, but they want the why. Why are we all going to be there? They want the what are we going to be talking about? How is the workshop going to unfold? And also who is going to be there? What are their affiliations? What are their titles? Can we have a short bio? So we're really becoming guided by this who, what, when, where, how, and why as we set up for the content of the pre-workshop in order to help prepare the community advisors to engage with the full team. And the third thing we're learning is this idea of safe disclosure. So as regards the interaction of the community advisors with researchers and policymakers, you know, it's probably inevitable that there will be things that the community advisors felt went well and things that they felt didn't go so well. I think if you've built trust and you are able to provide a mechanism for it, the community advisors will disclose some of these specific incidents or general concerns about any interactions with researchers and policymakers. So if you really want to learn about the patient engagement and grow that integratedness of your multi-expertise team, having a mechanism for this kind of safe disclosure of any kind of interactions that didn't go as well as hoped seems to be really important. So in our model, we used the post-workshop debrief as a mechanism for this, and also just the researcher community advisor liaison role. I think so the increasing inclusion of patients in this policy relevant research, it does represent a new way of doing things for researchers and policymakers alike. So there is much to be learned here in these micro interpersonal interactions and what that means for building effective teams. Okay, this is my last slide. So one final note about our engagement strategy. We've really tried to be mindful about the continuum of public engagement here specified by the International Association for Public Participation. They describe a continuum of engagement from, you know, simply keeping the public informed about the research issue, all the way through consulting with the public, involving the public, collaborating, and all the way to the end of empowering the public to be making nearly all of the research decisions. So we've aimed to keep a really open dialogue about the fact that public engagement does occur on a continuum, and that some decisions made about the research project you know, may involve community partners and policymakers at the informed level, whereas other decisions are made much more collaboratively. So in this particular project, I would say we sit largely at the consult and involve columns, but we aim to venture into the collaborate column where possible. So as an example, one of the deliverables we're pursuing is a description of the patient engagement strategy employed and some of the lessons learned. And much like this webinar today, this deliverable will be co-created alongside the community advisors group. So with that said, and a little brief mention of some of the lessons learned, I'm going to turn it over to Connie, who is our lead community advisor, and she's going to give us a bit of her perspective from a community advisor lens.
Thank you, Tara. You did extremely well. I learned again some more in our project. And to both you and Malcolm, It's been a team effort. I've learned a lot, and in my learnings, I've shared that with the other in our community. To all of you out there, some of the names on this list I recognize. When you submit your grant proposal, you need to use the word clients or patients. We've sort of zeroed in, and for me in particular, the word participant puts us on a level playing field with the research group that's out there. So you need to keep that in mind when you go forward and do what you're going to do. Anybody that I've been involved with that's interested in research, it's because we're interested and we want to be asked and we want to be at your table. Next slide. Language. I am not a researcher and I'm not a policymaker, and I learned a lot of language. Even today, I see that word Delphi coming up, and it took me a long time to finally get a definite definition of what that is. Things like topology, PHSI, another word that appears here, or acronym. Your community people don't know those words because they're not words we use all the time. The other point you're going to bring to the table, and I think it's a rich table if you are aware of where your community participants are coming from, the socioeconomic status, their education, their lifestyle. It's providing you with an opportunity to engage with community participants across a broad spectrum. And dependent upon the research you're doing, there are many people out there, and the older we get, the more experience we have in many aspects of bringing the stories to your table. Tara referenced this next one, respect and trust. Stories paint a picture that's worth a million words. You will not get those stories unless in any research you build trust and respect. And that becomes very important moving on. This next one, everyone gets a chance to speak and to be listened to. As our group of 30 plus, and we did a very good job in this project in mixing the groups between decision makers, researchers, and community. Everybody needs a chance to speak and to be listened to. And every now and then you will run into a person, and we've run into it in this project, where somebody takes over the whole time. And you got to be prepared to, how are you going to handle that? Because some of your community participants are going to feel not as educated, not as, their self-esteem, they've learned a lot through life, but their self-esteem, it's not easy for them to talk in a mixed group. So that has to be monitored. Next slide. The time involved, a communication plan. To the community people, they need to know what's happening. I was fortunate in this project because Taryn and I were on a first name phone call type basis walking through this. Your community people are out there in community, and every now and then they want to know what's happening. Where are we at? They also need access to an interim report or a final report. It may be in conference because of stuff that's in it, but there needs to be an ongoing plan. I mean, this project that we're talking about today is what, 2 years, I think, Malcolm, maybe 3. That's a long time for community people to be involved with no contact. I know that part of the timeline is allowing the researchers to analyze all the data they have, but not all community people are aware of that. Location and food. Well, we were fortunate in this project that we ended up doing the big pieces, the workshops at a local hotel. And that was good. I've been involved in other engagement projects, and we all need to be aware that parking becomes an issue in some facilities. Time of day becomes an issue in some locations. And if you want community involved, you need to make sure those two things are looked at. And feed us and we will come. It's very important if you're going to have people sitting for a whole day or a half a day or 2 hours in the evening, that nutritional food be part of the, whatever you want to, the event, I suppose. Those are my feedback on our project. I guess now we're ready for questions if there may be some. And I turn it over to somebody.
Chanel.
Malcolm or Tara, did you have anything else to add, or?
No, nothing that won't come up in conversation.
Okay.
No, not for me.
It'll come
Perfect.
up.
Well, thank you three so much. That was wonderful to hear about this work, and I think it's really you have quite a unique and deep patient engagement strategy, which is nice for all of us to see that example. And I especially, what resonated with me, which I haven't heard as often as maybe we should, is the comment by Tara about if we are engaging members of the public and participants and we're not a little bit uncomfortable, like perhaps we're not quite engaging them enough. So I think that that's a really great point that you added there, Tara. I'm going to open it up to anybody here who has any comments or questions. You can also leave them in the chat box if you don't want to speak using your audio. Feel free to list them in the chat, and Jen will keep track of that, and we'll read them out as they come. So you can either turn on off your mute and talk, or leave them in the chat. Oh, is somebody trying to talk there and can't? Okay. I have a question, and maybe Connie, you can speak to this. So in your talking about preparing for the event, so having everything that every different group needs, and talking about language, is there some tips you have for researchers out there to provide that pre-plan? So to provide the background of what we're doing and what kind of language should be used around that, and what kind of detail should be used around that?
I'm not sure it's detail as much as maybe a cheat sheet of some sort of research words that are going to be part of the conversation. And so that I can look at it and refer back to it becomes important. I mean, if I was in a partnership years ago with a person in education, and we were good at talking about education words on an ongoing basis. But if I'm in a relationship with somebody who's not education, and I start talking about education terms, oh, there you are being the principal, or there you are being the teacher again, it doesn't make for commonality. And with this package or this research, the researchers, there are words that are typical research words. You guys use them on a daily basis, community doesn't.
Yeah, that makes sense. Thanks, Connie. I think we have a couple.
So Chanel, I would add to that actually, if I could just for a second.
Sure.
And Connie, and again, the things we don't think of every day, but if we're working with some community partners, we want them to engage and appreciate their comment. The language, the names we put. So if Connie walks into a room and I introduce myself as Dr. Malcolm Dope, I'm the doctor piece. I'm Malcolm. You're Connie. I'm Malcolm. We're here to like that piece. But the other thing, and I've never thought of this, but the whole thing of, okay, so we call our healthcare partners decision makers. So they're the decision maker. How does that make the community person feel? Like I can give my input, but they're going to make the decision, and so those are phrases that we don't worry about too much from a normal point of view. But when you debrief with the community advisors after. This is the kind of stuff that comes up. Never mind the content of the workshop. Some important things to what do we call ourselves is an important piece on all this, I guess.
Absolutely, because it levels the playing field.
Yeah.
And when you think about the word decision maker, are they really decision makers? Because in effect, I've learned they are not. They will take what they've got from this research we're doing and move it up their system, whatever their system may be. But they're not final decision makers. Terminology, very important.
For sure.
We have a couple questions from the chat. One being, how do you choose which participants to include in your group and which ones to exclude?
Well, so anybody that's written the grant before, it's usually have one slide food under your table for the few weeks beforehand, or under a door. It's usually written in, and this is there's a lot of stuff to do in a short period of time. So I had known Connie from other projects, Connie, in the past, and so I'd reached out to you, Connie, to lead this process. We talked about individuals that we were interested in, but we really wanted people that had experience in this, and B, that weren't afraid to speak their mind. Really are the two parameters, Connie, that we put out there, and that was I can't think of anything else that we'd used.
The other thing is, and that's why when they introduced who I was, out in community, there are several, what I'm going to call frontline networks.
Yeah.
So if you're doing research around parents and children, we've got parent-child coalitions. If you're doing research around the seniors group, we've got senior centers, seniors clubs, that kind of thing. So if you find some key people at the community level that are part of networks, that could be the first step, depending upon what your proposal is going forward. In the youth area, there's a whole network through Recreation Manitoba that if I was looking for some people at the front lines that are directly connected to youth, we could find them. It's just having the right words and the right connections, because there needs to be the email and then the phone backup if there's any interest, because we're into email overload now looking for community people, I think.
I wonder if I could add something to my years and decades of actually participating routinely with the University of Manitoba's Café Scientifique. Some of the topics are pretty, they're all research related, but they have a way, and I guess it must be the organizers of the cafe, to approach people so that they can, it's not dumbing it down. That would be an insult to people, because there's a lot of people who attend those Café Scientifiques that are very interested in the topic, but they do ask a lot of questions. If you look at some of the videotapes of the Café Scientifiques, you'll see how they interact. And I don't recall them using, prefixes and introducing people as Dr. So-and-so or researcher so-and-so. So they use as Connie said, a playing level field so that everybody's comfortable and open, even if the topic is not comfortable.
Thanks, Trish.
Yeah.
Chanel, I have another comment to make, but I don't want to. If there's other questions, I'll hold it.
We have one other, but go ahead, Malcolm. And
yeah. Well, so the other thing I want to make clear is, having Connie and her colleagues involved with this is also very good from a researcher perspective, because Connie often asks the question, well, why are we doing this? You're going to look at this and Malcolm, give me the skinny in terms of why exactly are you doing this? And that's not an easy answer or a question to answer sometimes. And it really makes you stop and think about, well, hang on a second. Yeah, why are we actually proceeding with this? And what product are we going to get out of this? And how do we expect it to be used? And so I don't want to, this process of having the community partners involved is not something that benefits them. I want to say it that way. That going back to those three circles, it really pushes that middle piece and makes you think, oh, you know what? That's why exactly are we doing what we're doing, and what do we expect to get out of it? And I think this is a fair statement, Connie. This whole piece about keeps people, what do people need to live successfully in the community? That wasn't part of the grant. It wasn't written in as the grant. It was the original conversations with our community partners that they said, well, yeah, the healthcare system piece of this is fine, but all of this starts to fall apart if the community sector is not strong. And, what are you doing about that? And so it made us kind of go back and look at this from a little bit of a different lens. But it's a heck of an exercise to make you really, take all the research lingo away and the publications away and ask the questions, what practical impact do you want out of your study?
And to add to that, Malcolm, your community group, the people that are bringing their expertise, their experience, their life to the table have stories to tell that are an experience that are very vivid. And when you think about the current SPORE project that we're involved with, I personally am involved with three personal care homes, people in long-term care, 3 different facilities. That's experience. The other 2 people that are Winnipeg people on our collective grant have had that experience. And those stories for policymakers and researchers are vivid and real. And I take that and I take to other research that call me and want my experience or my ideas on stuff. And it's part of sharing where I've come from, where I've been, and it's like that for all community people. And the more we can share those experiences with researchers, the more the research going to government, going to policymakers, going to out in the community, it's helped because it's based in good, solid data.
One other question from the chat. I'm curious to hear more about the reminders that the researchers and policymakers needed regarding engagement with community members. So the 3 of you take that.
Tara,
Tara can answer that.
Sure. So I'll say that this is, I think, a real process in progress, right? So I talked a bit about the importance of having a mechanism for kind of safe disclosure of any incidents or any kind of interpersonal action or interpersonal occurrences that have happened that the community advisors have brought up. Equally important is that if you have a mechanism for this kind of reporting, you also need to figure out what you're going to do about it when something does sort of occur and there is for lack of a better word, an incident. So I think our team is still evolving with this, you know, because you don't want to single any of the groups out and call out any specific incidents in particular, but we've tried really hard to have consistent and regular reminders about this idea of level playing field and you know, acknowledging that each of us comes to the table with a different area of relevant lived experience. So, you know, as the community advisors are coming to the table with their most relevant area of lived experience being community caregiving, and researchers coming to the table with their most relevant area of lived experience being in the research process. While they may have other experiences, this is the lens that they're taking. And policymakers coming to the table with the lived experience of what it means to change or modify policy. So we've tried to have reminders about that at the outset of each of the workshops. But as I say, I think that, you know, it's a work in progress.
Yeah, the other thing I think that's important to add to that, when community people commit, they're committed. So each of the other groups have to be committed so that we're all one team. We're all involved in whatever the research is going. So you need the appropriate, if you're going to be on board with a research project, you need to be there, because if you're not there, then how do you know what the community people are saying? It's not always captured in words.
We have another question in the chat to the panel. From your experience, how can we better prepare our future researchers for engaging patients and community partners early in research programs?
Interesting. I'm going to share one of my, I ended up talking to somebody doing her, I think it was her first research topic with a community person. An hour commitment on my part ended up being an hour and a half because of the processes she learned through her questions and additional conversation. So maybe it needs some of, like, I think of the people that are on our research team or our community advisors, I would bet at least 2 out of those 3 would meet with future researchers and have coffee and conversation with them. And maybe that's what needs to happen, so that they're hearing from some of us about plain language, about commitment, about all of those kinds of things. That would be my.
So the only thing I would add, I mean, Connie, I agree with you, right? The only thing I would add to that, and this is by way of a bit of a story, I guess, but you know, we're trained in the research process to, you know, focus on rigor. You know, is the boss in many instances, and you know, we get into the weeds a lot, and in some ways that's our job a little bit. I remember I was chairing a PhD defense a few years ago, and someone that was a wonderful PhD defense, but the person, one of the external asked at the end of it, was the person passed. It was obvious they were going to pass, but at the end, almost for fun, the external said to them, "Okay, well, the Minister of Health just walked in and has got a check they're willing to write to you, but you need to tell that person in, you know, 2 minutes or less, you know, without being complicated, do not get no research lingo. Tell us why you've done what you've done, and so what, and what's gonna happen after this." And the person couldn't do it. And so we're not trained to think that way. So I think a lot of this preparing the future researchers is to not lose sight of the so what question, right? That does, if you want to engage with people, you have to have a non-researchy so what component to this. So you're going to lose people, I guess.
It goes back to those 5 W's,
Yeah, yeah.
or maybe there's 6. I don't know.
I would also add that there's just absolutely no substitute for experience. And so in this particular project, there are a number of students from Malcolm's shop that are working as part of the project. And I would say that they are getting like amazing training just by being involved in the process and seeing it all unfold and seeing firsthand, you know, what's working well, what's not working well, and how the team adapts and moves things forward.
I can probably relate some of the concerns that general public would have being in the clinical research field for about almost 17 years and having to develop an instant rapport with people who were coming in for clinical trials. Clinical trials, you know, had bad names to them. You know, they thought that we were going to get paid for every single person that came. We got big money, which that never happened. But we did have to make sure that we developed that rapport and trust and understood where they were coming from and explain everything, because our consent forms were in lay language, but the understanding of what was going to happen to them, they had to be on board with it in order to complete the research project. It was quite enlightening, and I really enjoyed doing that. But I also did the epidemiology study for inflammatory bowel disease for Manitoba, and that was challenging because I found I had more resistance, not from the patients, because I didn't have contact with them. I just had contact with them through filling out a questionnaire, but it was through the doctors. I had to do the same thing to gain their trust. That I was reviewing their charts for the purpose of the research, not to look at them as a physician or whether they did X, Y, or Z right. Similarly with patients, that they were going to do things the right way because I was going to help them do it. And the outcome was going to be either for or maybe not, you know, for them or not with them, in terms of whether or not they got a drug or not.
So I think it's really interesting to sit back at these workshops. I would say, Tara, and you know, what do you think of this? But and it's not a bad thing. It's just different perspectives. In terms of, never mind the researchers, but the healthcare planners and the community people. And you know, one group, you know, the healthcare planners will, you know, look at the system and will look at it from the point of view of, you know, who pays for what, length of stay, you know, admission criteria, et cetera, and to have the community people feel empowered enough, I'm going to say, Connie, to step in and say, well, hang on a second, when did we decide that a long length of stay was a bad thing in a nursing home? Who decided that, right? And so it takes it's really cool because it takes the conversation and turns it on its ear a little bit. And if the researchers are listening, it also has great insight into how you would set up even to do some analysis in big data when you're looking at things like length of stay. And so it adds a huge richness to the conversation as long as you empower people to speak their mind.
Yeah, I think that it's sort of fascinating and exciting to watch that happen. I think, you know, there's really rich capacity building that's going on between these three types of participants. So researchers learning more about the policy process, and community advisors learning more about the policy process, and everybody's learning about the research process, and we're all learning from the community advisors about the lived experience. And so that capacity building and that capacity development is really exciting. I think there's something probably to be said for, and we're learning as we go in this area too, for you know, the unintentional sort of side effect of capacity development that happens. There's maybe something to be said too about at the beginning of a project, maybe some more formal inclusion of capacity building in those 3 areas of like lived experience, research process, policy process, so that we're all coming to some common knowledge on, you know, the backgrounds of each of the individuals coming to the table, or each of the groups coming to the table.
I just want to react to what Alana is saying here. I think it's really important. You're bang on, Alana, with the fact that the pre-workshop prep session really was successful, but it's project specific. So if you take a step back and ask the question of, you know, so how do you prepare individuals to be part of a research project or program? Is there formalized training that can happen? You know, can you provide some sort of methodological training that would be helpful? You know, I'm not sure I have the answer to that, but I think what MPN is trying to do in terms of bringing together a group of patients and community partners to really even just support one another, to stay informed, is a great step in that direction of prepping individuals for just the conversations that need to happen to be a partner in research. You know, and I like I said, I can't answer the question around, is there formal training that needs to happen? So, you know, Connie, to put you on the spot, I don't know, what do you think about that? Like that more generic kind of research training?
About the research training, I'm not sure, but I'm going to tell you that there needs to be some sort of behavior training in terms of acknowledging or being aware of the body language. If you're a good communicator and if you're watching for different signs of people opting in, opting out, opting in too much, and you have that background in behavior analysis, and you bring groups together, all 3 groups, in terms of this project. I mean, I can sit there and people watch and do all kinds of behavior analysis. Our young researchers maybe haven't had that kind of training and would need that if you're going to engage more community. Because with this project, Tara and Malcolm have a process, and the process works as long as the young researchers can recognize some of the stuff that's happening.
Yeah, I don't know. I'm looking at your question too, Lana. I don't know if it's a formal training program. So, well, you and Gail have come into the Manitoba training program and given a session on engagement with the community, and you know that I could see that, you know, being built out or stretched or, you know, whatever, to added in a few more things. I mean, I think the manuscript, Tara, that you and Gail are working towards on this, you know, kind of here's some things to follow, right, as you're doing this, would be a really good starting point.
Yeah, that's some work that Gail and I are doing, and the community advisors will be a very big part of putting that deliverable together in terms of describing sort of what are some of the things that the community advisors feel that they need in order to be prepared to engage in a full team workshop.
Thank you, guys. We're at 1 o'clock now. That was a really good discussion and an excellent presentation. So thank you so much for your time and sharing with us. And thank you to all of those who attended here.